I want to say I will be in a couple of months 70, so the presentation of Philip actually give me a good expectation for the future. I will talk about failed subacromial decompression, the etiology, and the treatment. First, this is the technique we use for subacromial decompression. We use the so-called measuring needle to measure the subacromial space by placing two needles, one in the medial and one in the lateral corner of the anterior acromion. Then we remove the fibroses and adhesions, and then we cut the ligament from its insertion at the anterior acromion, the coracoacromial ligament, and finally we do the decompression using burr or acromionizer, and then we measure the space after that. The results are mostly good results, especially as you see on the left, the space is about 1 millimeter, and after decompression can be up to 14 millimeters. So it relieves the tendon from any compression from above. Now, the causes of failed of anterior acromioplasty are incorrect diagnosis, technical error, mainly too little bone removal, or inadequate rehabilitation, or even unrealistic post-operative expectation, as in athletes. Post-operative complications of anterior acromioplasty are hematoma, rupture of the biceps tendons, acromion fracture, chronic shoulder pain, chronic shoulder stiffness, damage to blood vessels or nerve, and infections, which actually happens in open repair. Now, we developed the etiology, or we classified the etiology of impingement as a guideline for treating the subacromial narrowing into upper causes and causes in the subacromial space itself, and lower causes. The upper causes are mainly from the acromion or the acromioclavicular joint, and the causes in the space are thickened bursa or effect of the coracoid impingement, and the lower causes tendon lesions, instability, or greater tuberosity lesions. Now, what happened if we do too little bone resection? This is actually the most common cause we see in our clinic of failed subacromial decompression by not removing enough bone from the anterior acromion. Also, a wrong bone resection means we have some cases with persistent pain after decompression, because the decompression was done in the middle of the lower surface of the anterior acromion, leaving the prominent present and causing impingement again. Or in cases of AC joint osteoarthritis, we may have a failed revision because of the presence of the spurs in the AC joints, the bone spurs, causing impingement. So the treatment of that is either to remove the spurs in case the AC joint is not symptomatic, the AC joint osteoarthritis, or if it is symptomatic, we resect the lateral end of the clavicle and do an acromioclavicular joint arthroplasty. The anterior acromion protuberance is also one of the causes of failed subacromial decompression, in which the protuberance is not resected, and it stays to make problems on active elevation. So this will need a revision and removal of the protuberance. Now, what about lateral acromion? Also recently it was talked about in many papers, that the lateral acromion is also a cause of impingement. This also happened, but it is not very much cases which we see of that. But we can diagnose that preoperatively from the clinical examination and the X-ray, or from MRI. So in these cases, we have to resect the protuberance in the lateral acromion, and this is also one of the causes of the failed subacromial decompression. Now, in some cases, there is an open acromial epiphysis, and non-union of the epiphysis, mainly the anterior one, which is the periepiphysis, or the middle one, which is the mesometaepiphysis. This non-union, if not dealt with, may lead to a failure of the decompression. In case of the periepiphysis, it will be resected, but in case of the mesometaepiphysis, reconstruction and closure of the epiphysis should be done using K-wires and cerclage, either open or arthroscopically. Now, another problem for failed anterior acromioplasty is after decompression, there may be a gap present if you remove too much bone, a gap between the anterior deltoid and the anterior acromion. And this causes weakness of the anterior deltoid and problems. This has also to be treated by reconstruction of the deltoid and suturing it back to the anterior acromion. Also, a postoperative fracture of the acromion can happen after a decompression, especially when the decompression is done in the middle of the acromion. Now, in cases of all dislocated AC joint suspensory mechanism, even if we do an anterior acromioplasty, we may have a recurrence because there is a loss of the suspensory ligaments and leading to an increase in slope of the acromion. In this case, reconstruction of the AC joint is indicated. Now, what about the inferior causes or the lower causes of the impingement, which we have to keep in mind in our diagnosis and treatment? And if we not take care of that, it can lead to a failed subacromial decompression. Well, the second most common cause which we face in our clinic is the partial supraspinated tear. That after decompression, the pain persists, and the reason is that the partial tear is not dealt with while doing the decompression. Of course, the treatment, we have to repair this lesion. Calcium and even thickening of the supraspinatus tendon can lead to narrowing of the subacromial space. As we see here, the tendon is bulged superiorly, causing an inferior cause of narrowing of the subacromial space. Here we have to remove the calcium and clean completely from the tendon. And then after that, we have usually a gap in the tendon, which has to be then sutured with the transosseous reconstruction. After doing that, we measure then the subacromial space and we see if the distance is okay or not. If it's still a narrow distance, we do then repeated subacromial decompression. Now, this is a lesion which actually we call it the spoon lesion, which we notice in our clinic that supraspinatus is very loose and elongated, which happens mainly in young people, found it actually in the 20s to 30s. A histological analysis of the tendon showed that there is increase in fibrosis of the tendon compared to a normal tendon. We don't know why is that or what is the reason. We can only hypothesize that it's maybe microtrauma or activity or something else. So here we do also a resection and a transosseous refixation to stabilize the joint and treat the impingement problem. Now, open rotator cuff interval can also lead to recurrence after decompression because the head is not stable and will go up, causing narrowing of the space. In this case, also we have to do an arthroscopic closure of the open interval. Frozen shoulder, as said also before, it can cause also an impingement, and not dealing with that during the subacromial decompression may lead to failure. We have to release the adhesions and even do the capsulotomy. And then after that, we see if we need to do a subacromial decompression according to the size of the subacromial space. In cases of multi-direction instability or subluxation impingement, here we have also a dynamic narrowing of the subacromial space with elevation of the arm. In this case, we usually do a treatment of the capsule and do an inferior capsular shift to stabilize the joint and prevent the superior migration. Also, a Hagel can lead to an instability, a Hagel lesion. In this case, also we have to repair the Hagel lesion, and even after decompression, we do another revision and do the stabilization or reinsertion of the subscapularis to the humeral head. Prominence of the greater tuberosity can also cause recurrence after decompression. This prominence is either due to malunion or non-union displacement of the greater tuberosity, or even in cases of congenital prominence, as in case of Ehr's palsy. And the treatment here, what we do is an arthroscopic removal of this bony protuberance and reinsertion of the supraspinatus. Now, the causes which are in the space itself are causing narrowing of the subacromial space. We observed here that after the decompression, we find cases in which the supraspinatus tendon sticks to the lower border of the acromion and causing impingement-like problems. Actually, we saw that also even in cases who didn't have a subacromial decompression. This observation led us also then to do an arthroscopy and release the supraspinatus tendon from the acromion. Also, coracoid impingement can cause of failure of subacromial decompression or treatment of impingement, because it can cause also inflammation in the subscapularis and then an impingement similar complaint. Here also, we do arthroscopic resection of the prominence of the coracoid process. Now, bursal calcification can also happen in the bursa and cause an impingement problem. And after decompression, remnants of this calcification may persist during the impingement problem. So we have to be very careful and clean all the calcium present in the bursa to prevent failure of the decompression. Now, expectations by some patients are maybe very high after the decompression, especially in athletes. As here we have 100 cases of decompression in athletes, which are mostly done in weightlifters and gym tennis, handball, and water polo. And these patients, they want to go back quickly to their sport, which may cause failure of the treatment and recurrent bursitis. So it is very important to follow these patients and always have them in contact with the clinic till they are completely relieved and they are ready then to go back to their sport, which actually may take even up to 4 months. So in general, the main causes of the failed acromioplasty in our vision are diagnostic, technical, or false rehabilitation. And the causes may come from incorrect or technical problems from superior causes for acromion or AC joint, or from inferior causes involving the tendon, the greater tuberosity, and instability, or causes in the space itself. Thank you very much for your attention.